Hello everybody, my name is Naveed Sattar. I am privileged to be a Professor of Metabolic Medicine at the University of Glasgow, and here is Glasgow in its sunnier days. I have, working with many teams around the world, published more than 900 papers, which seems rather a lot, but much of the heavy lifting and clever work is done by colleagues around the world, and often my job is to make sure that towards the end of the process, the papers look as robust as they can be, and that we've considered all the relevant caveats and made the paper say the messages that we wished it to say in the most concise manner. My main expertise is the links between obesity, diabetes, and heart conditions. I still see patients in these areas. I'm involved in several lifestyle and drug trials. So that's lifestyle in terms of weight loss and activity and diet, and drugs where we test the benefits of new drugs against often placebo tablets for their effects on heart risks. And we also look at their safety, which is really important. I also have the privilege working with many colleagues, experts around the world, to summarize evidence on specific disease areas, particularly around heart disease and diabetes, and come up with some guidelines which help colleagues. And I'm an associate editor for a journal called Circulation, which is currently perhaps the top cardiovascular journal in the world. Outside of work, and it's important to have a life outside of work, my biggest pleasures are, of course, my family, but also walking my dog. Here she is on top of Ben Ann, which is a brilliant walking spot if you haven't been. I love cycling and cycle to work every day, which is something that keeps me young at heart. And I play football with friends as often as I can. And hopefully this will resume shortly post-lockdown. In terms of research and COVID, I'll go through this relatively quickly. We know, for example, in the top left, age is the biggest risk factor for those people who are above 80 tend to have a several-fold higher risk compared to people who have an age under 40, for example. The male risk seems to be higher than we anticipate. It's around about double for dying from COVID-19, compared to normally it's about 30% higher than the average female. The ethnicity risks, both blacks and South Asians, risk seems to be higher than we would anticipate. There is a link to deprivation, higher COVID mortality, and there is a link for those people with prior conditions and higher risks. But it meant, again, age being the biggest risk factor. The areas where Glasgow has helped is looking at obesity, which I'll show you in the next couple of slides, and also vitamin D, which I'll show you in one slide. We've also contributed to diabetes, looking at national data sets within Scotland and England. And here the evidence seems to suggest that if you have type 1 diabetes, which is the condition where the pancreas has stopped making insulin and therefore you need to take injections of insulin, the risks seem to be threefold higher for type 1 compared to the general population, particularly concentrated in older people with type 1. And in type 2, that risk on average seems to be double. So twice the risk compared to people without type 2 diabetes. And type 2 is linked more to obesity as a driver for type 2 diabetes. In this particular study, so here is the link between body mass index and COVID-19 infection and death. This is a study where we took advantage of a study called UK Biobank, which has data on 500,000 people across the UK and followed them up since 2006 to 2008. So followed them up for about 10 years or so. Many risk factors measured a decade ago, and we looked at BMI, and when the COVID data were put together with this data set, we were able to show that the higher the BMI on the left, the higher the risk for COVID-19, up to about 3 times higher risk when your BMI was very high. And for COVID death, that relationship seemed to be slightly stronger, particularly for those under 50, which is the blue line. So that by the time you had a body mass index of 35, your risk for COVID-19 death might have almost been 6-fold higher than if you had a BMI of 20 and you were below 70. This work helped governmental reports on COVID-19 and obesity. And I think that was something that was important to highlight because it made the government think about obesity more seriously than it has done in the past, particularly in helping people prevent becoming obese in the first place. If I was to summarize this, and I'll do this in this kind of cartoon, if you are lean on the left, that you're further away to begin with from the threshold for severe COVID-19. But if you carry excess fat on the right, you are closer to begin with for having to this threshold for more severe reactions. And part of that reason being is that excess fat impairs lung function, impairs blood vessel function, your heart, your metabolism. It might exaggerate the way the immune system goes into overdrive with COVID-19 reaction, so that the combination means that not only are you closer to the threshold for a more severe reaction, but you also have a greater hyper-inflammatory response, which is the kind of hallmark of COVID-19. And in other words, the immune response goes into exaggerated overdrive for reasons we just don't fully understand, and that excess fat might be part of this. This kind of work needs further work. We put a cartoon together for our colleagues around the world, and I'm not expecting you to read the details, but effectively excess fat may both worsen the immune response on the right, but also reduces the buffering capacity of your lungs, your heart, blood vessels, your blood, etc., to cope with the severe reaction. The final data slide I want to mention is sort of vitamin D and COVID risks. Again, we return to COVID, so the UK Biobank, and where vitamin D had been measured about in all 500,000 people. And here we were able to show that vitamin D levels, which were low, were related to more deaths. But here the important point is we already know that vitamin D levels are lower in older people who are sicker, who are heavier, in smokers, who have lower affluence, who are non-white races. So these are called confounders. So it's important when you do this kind of work to adjust for these confounders, to try and look at the independent association of vitamin D, as it were, on the risk for COVID-19. And when we took all these confounders into consideration and tried to adjust for them using statistical analysis, we did not see a relationship between low vitamin D levels and the risk of COVID-19 death in a paper that's about to be published in the European Journal of Nutrition. And this work and earlier work linked that we did in vitamin D was used by what's known as NICE, which is the National Institute of Clinical Excellence, a rapid report they did on vitamin D to say that at the moment there was no clear evidence that low vitamin D was necessarily a cause for more severe COVID-19 reactions. What we really need in this area to advance whether vitamin D is or is not important is to do a randomized trial of vitamin D against placebo, and a couple of these trials, at least I'm aware of, are underway around the world. The final point I would make is that good research, when you do this in COVID-19, it's got to be agnostic to the findings, i.e. you've got to be open-minded to what the result may be. It's got to consider, it has to consider the potential confounders or biases, and that often requires a good team that covers different skill sets and experience to understand what the confounders might be and how to overcome them. You have to understand the limitations of your study. Any one study often does not give you the truth unless it's one major randomized trial, which is done fantastically well with sufficient power. You also have to place your results into wider context and suggest what other evidence is needed to make firmer conclusions on any particular area. So, for example, our vitamin D findings are not definitive, but they do not at the moment support a strong reason to consider vitamin D is going to supplementation is going to prevent COVID-19 reactions, but we need randomized trials. So it will push people to do randomized trials to test that. And the final point I would make about COVID-19 research is it's really rather tricky, because one of the things that we don't know about COVID-19 is who has had the infection. And that's very tricky, because often that means we don't know what the denominator is, and that makes our statistics and analysis quite difficult. And there may well be a confounder in all of this, that the people who get more of infections are the same characteristics of the people who we have linked to more severe disease. But that, again, needs more research. I'll stop there. Thank you for your attention, and I'd be happy, of course, for you to contact me to answer any specific questions as we go forward. Thank you very much.